Liverpool Heart and Chest Hospital, and I've also been working in the Knowsley Community Respiratory Service for over 10 years. So I think the crowd is small. Maybe we'll leave the question till the end. If you do pose any question on the message box, I might not be able to see it when I'm sharing my screen, but I'll try to answer them at the end. So what we will talk about today is COPD. I think one of the reasons why I was got asked to talk about this is because let me just admit a few people first. Because it is a common lung disease. However, it's actually not the most common chronic lung disease itself. The most common being asthma. This is the second most common chronic lung disease that we look after. So I'm going to break the talk up into 4 sections today. So first section, we'll talk briefly about the definition of COPD. Secondly, about the pathophysiology of COPD itself. Thirdly, is about the effects and clinical manifestation of COPD. Lastly, about the management. And I guess for the purpose of the virtual world, I guess the management is probably the section which is the most relevant part. So COPD is the term that we use nowadays. It stands for chronic obstructive pulmonary disease. But if we go back to, say, 25, 30 years ago, it was actually used to be called COAD, which stands for chronic obstructive airway disease, which was an umbrella term that encompassed a number of obstructive lung diseases, such as the bronchiectasis, chronic bronchitis, emphysema, cystic fibrosis. But one of the reasons why the terminology was changed is because one company realized that actually cystic fibrosis is actually quite different from bronchiectasis, it's different from emphysema. Therefore, this umbrella term actually become very confusing. As such, this lead to the inception of what we called COPD. Sorry about this. It's a technology thing. Okay, so what does COPD comprise of now? Actually, there are only 2 phenotypes. This is defined by NICE guidance in 2019 and also defined by the British Lung Foundation. So one type is called emphysema and the second type is chronic bronchitis. I'm sure many of you have heard of emphysema before. It is basically destruction of the alveoli where gas exchange takes place, and they get replaced by scar tissue called emphysema. And the most common cause of emphysema itself would be cigarette smoking. So what's the difference between emphysema and chronic bronchitis? Well, emphysema is very much what we call a pathological diagnosis, or sometimes we call radiological diagnosis, because we can only diagnose emphysema through X-ray, but more commonly through CT scans. So the definition of emphysema is the abnormal permanent enlargement of the air spaces distal to the terminal bronchioles, accompanied by the destruction of alveolar walls and without obvious fibrosis. So basically destruction, in simple terms, destruction of the alveoli where gas exchange takes place. So you can imagine that if the alveoli get damaged, gas exchange cannot take place. So clinically, that's when the patient will present with symptoms of breathlessness. In severe cases where a lot of alveoli being damaged, in other words, there's a huge amount of emphysema, that's when we will see the patient being hypoxic because oxygen cannot get through from the destroyed alveoli into the bloodstream. The other definition of COPD, or the other phenotype of COPD, is chronic bronchitis, and this is very much a clinical diagnosis. I won't read it out, but in simple terms, clinically is when patient cough up phlegm on most days of the week for a number of years. That's what chronic bronchitis is. And I think if we go back to the definition of emphysema, definition of chronic bronchitis, we're kind of building a picture in terms of the clinical presentation of patients with COPD. So breathlessness, wheeziness, cough, producing phlegm of variable color, and the phlegm can be of different consistencies. Sometimes it can be quite easy to bring up. Sometimes the phlegm can be quite sticky, quite tenacious. Therefore, they will find it difficult to expectorate. And because in those patients who have got inflamed lungs or with a lot of phlegm, that can no doubt attract the risk of recurrent chest infections. because the phlegm is like chewing gum. So once the patient breathes in the sticky phlegm, they may be at risk of getting chest infection as a consequence. So what is the definition of COPD? Well, this is the latest definition as defined by GOLD. So for those of you not familiar with GOLD, GOLD stands for the Global Initiative for Chronic Obstructive Pulmonary Disease. So in the UK, we use something what we call NICE guidance. In the US, they use GOLD. The purpose of GOLD is basically give guidance to clinicians like ourselves, the way how to diagnose COPD and the way how we manage COPD. But the key difference between NICE and GOLD is that NICE guidance get updated every 5 years, although it doesn't always happen, because if we look at the GOLD guidance, the most latest update was in 2019. And before then, the update was in 2011. So it's actually over an 8-year period, whereas for GOLD, they get updated every year. So this is the latest definition of COPD as defined by GOLD in 2023. It defines COPD as a heterogeneous lung condition characterized by chronic respiratory symptoms. So heterogeneous, I mentioned before, you get two types, emphysema and also chronic bronchitis. And chronic respiratory symptoms, which will comprise of being breathless, coughing, bringing up sputum, getting recurrent chest infections, is usually due to abnormalities of the airways. So in patient with emphysema, it is the abnormality will be within the alveoli. And for patient with chronic bronchitis, this will be inflammation of the bronchi itself, and usually progressive. So I think we all agree that COPD is a long-term lung condition. So strictly speaking, as long as we get the diagnosis correct, once a patient gets COPD, it never quite disappear. It tends to get worse, and they tend to get worse more rapidly, especially in those patients who continue to smoke cigarettes. Whereas for those patients who manage to stop cigarettes, stop smoking, COPD can still progress, but usually at a slower rate. And I've got a graph I'll show you later on to illustrate the deterioration lung function in patient COPD over the course of time. It is also characterized by airflow obstruction. That's why spirometry is helpful to make a diagnosis, because by definition, patients with COPD, they're supposed to have evidence of airway obstruction on spirometry. However, in real life terms, COPD doesn't just happen on its own, because you can imagine that the most common cause of COPD is actually from cigarette smoking itself. So cigarette smoking doesn't just cause COPD, it causes many other lung issues. It also increases the risk of ischemic heart disease, cerebral vascular disease, hypertension, hypercholesterolemia, cancer as such. Therefore, I think when we come to deal with patients with COPD nowadays, usually the patient may have several other diagnoses. However, when we do come to diagnose COPD, I think it is also important that we can differentiate this condition from another very common chronic lung disease called asthma. So this is just a table to illustrate the difference between the two. But before I go on anymore, there's also something what we call COPD asthma overlap. It is a condition which is increasingly recognized, especially in the last 5 to 10 years. So one example would be if somebody is born with asthma at a young age or had asthma since childhood, they go on to smoke cigarettes significantly in the adult life. It is definitely possible for the patient to have a bit of asthma, a bit of COPD, and that's the reason why some patients do have what we call asthma and COPD overlap. But I think one key difference, which I highlight between the difference between asthma and COPD, is that COPD is a progressive condition, whereas for asthma itself is supposed to be a reversible condition with treatments. So if we come to examine patients' clinical symptoms, usually when they complain of breathlessness and COPD, over time it gets worse and worse. Whereas for asthmatic, they may get some good days and bad days. You can imagine that there are actually many elite athletes have also got asthma, and yet again, they actually excel in their sports. The reason for that is because when the symptoms are well controlled, the chest can be just the same as somebody who have got no asthma. I think that's a key difference. And also when we come to other symptoms such as the diurnal variation symptoms for COPD wise, it tends to be throughout the day. And sometimes they do get nocturnal symptoms, but whereas asthma-wise, sometimes the symptom can be worse at nighttime. So when we come to ask patient history of asthma about how well the asthma is controlled, sometimes we'll ask them, how often do you wake up in the middle of the night because you get wheezy chest, you have a cough, you get breathlessness to a point where you have to use your rescue inhaler, which is the blue salbutamol inhaler. So in patient asthma, typically when symptoms are not well controlled, they get a lot of nocturnal chest symptoms. As I mentioned before, asthma COPD overlap is definitely possible. In fact, there are also some patients, not just that they got COPD, they've also got underlying bronchiectasis. And we have got some patients where they don't just have bronchiectasis COPD, they got asthma, COPD, bronchiectasis, lung cancer, fibrosis. And I guess as patients live longer, the lung condition tend to get a bit more complex. Therefore, very commonly, we don't just deal with COPD alone. About 20 to 30% of patients do have a number of chronic lung diseases all in one patient. And what about the pathophysiology of COPD? This is really just for interest, but hopefully that might explain the reason why patients present with these symptoms. So on the top left-hand corner, this is the cross-section of what we call the alveoli. So this is the air sacs where gas exchange take place in the lungs. So in the healthy individual, which is the top left-hand corner, the alveoli is wide open, so air can go in and out easily. That can penetrate through the semi-permeable membrane, and then oxygen can go through the bloodstream, and from the bloodstream, it can pump around the body. But the bottom left-hand corner is when patients got COPD, especially with emphysema. So what happened is the attachment that held open the alveoli gets destroyed. Therefore, the alveoli become collapsed. As a consequence, air cannot go in and out freely into the lungs. So you can imagine when you start getting turbulent flow of air, that's when patient will get wheeziness because air is not going to be going in and out of the lungs smoothly. Secondly, in patient with emphysema, not just that the airways become collapsed, is the underlying inflammation within the lumen of the airways, that what we call bronchitis, that lead to a production of phlegm as a consequence. So this will clearly explain the reason why the patient with COPD can get out of breath, they can get wheeziness, they can also get recurrent sputum production. And some of you may have come across a very rare lung condition called alpha-1 antitrypsin deficiency. So this probably accounts for 1% of the patient with COPD. If we look at the NICE guidance, when do we suspect a patient with COPD who may also have alpha-1 antitrypsin deficiency? This is a genetic disorder that can run in the family. So NICE guidance suggests that anyone who presents with COPD less than the age of 35 years, we should consider alpha-1 antitrypsin deficiency being a cause. But how do we make a diagnosis of alpha-1 antitrypsin apart from saying, well, the patient got COPD? And we'll talk about the diagnosis later on. It's very easy just to ask for a blood test. Just ask for alpha-1 antitrypsin level. If it is low, very likely the patient has got alpha-1 antitrypsin deficiency. Then you may also ask, so what's the treatment if the patient has got alpha-1 antitrypsin deficiency? Unfortunately, the answer is no. There isn't any genetic treatment available. So the treatment for alpha-1 antitrypsin deficiency would be exactly the same as patient with COPD. Then you may also ask, well, what's the point of making a diagnosis then? Because it doesn't change the management. Well, in terms of pharmacological management, probably no change. But I think there are actually two very important points to diagnose someone with alpha-1 antitrypsin deficiency. Number one is genetic counseling. Secondly is for patients with alpha-1 antitrypsin deficiency, if they go on and continue to smoke cigarettes, one thing we know is that the lung condition tend to progress a lot quicker than patients who smoke cigarettes alone with no alpha-1 antitrypsin deficiency. Needless for me to say, smoking cessation is paramount in any condition, whether they've got lung condition or not. However, for a patient with alpha-1 antitrypsin deficiency, if they continue to smoke, I think they're really playing with fire because the lung will actually deteriorate a lot quicker compared to those patients who just smoke cigarettes with no alpha antitrypsin. So smoker cessation is vitally important for these patients. What about the muscle tone of the airways and the active breathing? Well, within airways itself, there are two neuroreceptors. I'll just go through them. One is called the beta-2 receptors, and the other one is what we call the muscarinic receptors. The reason why I want to bring this up is this may explain some of the medication that we use for the management of COPD. So the beta receptors are within the airway lining or the respiratory epithelium, and any stimulation of the beta-2 receptors will lead to what we call bronchodilation. So one example of beta-2 antagonist or agonist would be salbutamol, Ventolin, Salamol. So you give patient these inhalers that will stimulate the beta-2 receptors, leading to bronchodilation that can help the patient address the symptoms of breathlessness and wheeziness. There are also something what we call muscarinic receptors within the airway epithelium or airway lining. And any stimulation of the M3 receptors or the muscarinic receptor can lead to bronchoconstriction. Therefore, if we have a medication that can block off the receptors, that will lead to bronchodilation. And that's the reason why we get these muscarinic antagonists, or sometimes we call them long-acting muscarinic antagonists like LAMA. We also get the LABA, which is a long-acting bronchodilators or beta-2 agonists. So if you've got a medication which is a LAMA and LABA, that will lead to dual bronchodilation, that in a way can improve the patient's symptoms of breathlessness compared to what we call a single therapy, monotherapy, like a LABA alone or LAMA alone. I hope this makes sense. This is just for interest, but hopefully that will explain the rationale of some of the pharmacotherapy that we use for the management of COPD. This is just how the distribution of different receptors within the lungs. Some of them are in the very distal part of the lungs. Therefore, when we come to using inhaled therapy, we do want to use inhalers with small particle size, because you can imagine that the bronchial tree is like a tree which is hang upside down. The further you go, the branches get thinner. Therefore, to get the maximal benefits of inhalers, you want inhalers that have particles of small size that can actually go to the distal part of the lungs, to the smaller branches of the lungs, that can lead to what we call maximal bronchodilation. Hence, the patient get maximal symptom benefit. What are the clinical effects of COPD? Well, I mentioned before in COPD that there are damage to the lung tissues, and also in patients with chronic bronchitis, there's inflammation of bronchi that lead to excess mucus production, that also lead to inflammation within the airways. And because the airways become narrowed, it becomes more like a one-way valve. So what happens is when you ask a patient to take a deep breath in, and when you ask them to take a deep breath, breathe out, the tube actually collapse. Therefore, they can't empty the lungs. So that's the reason why sometimes we say the patient got hyperinflated lungs. When we look at X-rays of patients with COPD, they look very long, they're hyperinflated, because you can imagine you keep blowing the balloon, but yet again, the balloon does not allow air to come back out. So as a consequence, patient get hyperinflated lungs, very big lungs, very long lungs. And over a period of time, patient develops symptoms of breathlessness, the exercise tolerance become reduced, they get chest tightness, wheeziness, recurrent chest infections. But COPD can also sometimes lead to systemic symptoms, because in patients with COPD, they get chronic inflammation within the lungs. As a result, the lungs produce a number of inflammatory hormones, or sometimes we call it cytokines, as we call it. All these inflammatory hormones got negative effect to the human body, in that it can lead to the loss of weight. But weight loss is not always just related to inflammatory hormones production within the lungs. As the patient gets more out of breath, the appetite goes down, they lose weight, and also because sometimes they're actually burning off quite a lot of calories just to help them to breathe. So some of you may recall something what we call pink puffer and blue bloaters. For the pink puffers, this mirror what we call the emphysema in the patients. So usually these patients are very breathless. They've got a very high respiratory rate, because they breathe so quickly, they burn off a lot of calories. As a consequence, they lose weight. Some patients with COPD can also go on to develop osteoporosis because the inflammatory hormones can actually lead to an increased turnover of the bones, leading to brittle bones, weakened bones, osteoporosis. And the other thing, which probably is quite relevant to the virtual ward, is that for those patients who have COPD exacerbation, most of them will get corticosteroid, prednisolone, steroids. And I'm sure you all agree with me that one of the side effects of prolonged or repeated courses of corticosteroid is osteoporosis. So that'll be one other reason why patients with COPD can also get osteoporosis. NICE do suggest that for those patients who go on to have repeated courses of corticosteroid within a 12-month period, they should be considered for a bone density scan or DEXA scan to evaluate the bone health. But exactly how many courses of steroids the patient need to go on is not clearly defined. But generally speaking, from my point of view, is if the patient have maybe 4 or more courses of oral prednisolone over a 12-month period, or for those patients who are on maintenance prednisolone, I do think that they probably need periodic bone density scan to evaluate the bone health. And lastly, some of these inflammatory hormones can lead to negative effects to the patient's mental health. So anxiety and depression is quite common. In fact, in the context of COPD, between 10 to 40% of patients with COPD also get associated depression. I think when we come to a virtual ward, when we speak to the patient, especially after an exacerbation, that's when all these inflammatory hormones are produced at high level. Some of them say they feel tired, some of them they feel low in mood. So that's definitely plausible. But of course, sometimes it can also become a little bit difficult to judge their mental health, especially when they're not well, when they're on corticosteroid, because one of the whether you call it side effects or one of the adverse effects of corticosteroid is that it can affect the patient mood as well. It can actually go the other way, make some patients actually feel a bit more euphoric when they're on corticosteroid. And in terms of natural history of COPD, so if we start at the top right-hand box, so in patients with COPD, you get functional health deterioration, they get out of breath, they're not able to do things they're able to do. They cannot walk around as much. They cannot do the housework. They can't do the shopping. Some of them can't go back to work as a consequence. Therefore, undoubtedly, this will lead to a reduction in their quality of life. And this also leads to anxiety and depression because obviously loss of income, they become more dependent on their family members to help them do things. Sometimes they even struggle to make a cup of tea. And as the COPD progress, that lead to recurrent exacerbation and progression of lung disease. So this, in a way, becomes a bit of a vicious circle. So if we look at the management of COPD itself in terms of chronic management, I guess we need to find a way to break the cycle. So how can we improve the patient health deterioration or functional status? Well, pharmacotherapy. There are also very good non-pharmacotherapy for pulmonary rehab that can also improve the patient fitness level. They can do a bit more. Hopefully, that can improve the quality of life. If they've got associated anxiety and depression, there are good anxiolytics that can be used. Psychotherapy can also be offered to some patients. And of course, on the top left-hand corner, they get breathlessness, they get recurrent exacerbations. We can treat them with inhalers because some of the inhaled therapy has got evidence to show that they can help to reduce the exacerbation rate. And for some patients who get uncontrolled exacerbation despite on optimal inhaled therapy and have also stopped smoking, sometimes maybe the use of long-term antibiotics can help. One example would be the use of azithromycin. So hopefully all these interventions can help to break the cycle of, progression of COPD. But unfortunately, sometimes regardless of what we do, some patients continue to deteriorate, they die. Now, I'm just going to change the topic a little bit. I'm just going to briefly talk about the epidemiology of COPD. I mentioned before, it is the second most common chronic lung condition after asthma itself. In the UK, about 1.2 million people have got COPD, but there are probably about 2 million people with COPD that are not currently diagnosed. But I'm sure we've seen some of these in the virtual ward. So these are patients who never go and see anyone. They go to see their practice nurse. They don't go to see their GPs. But when they become well, they go A&E. And that may be the first presentation and when they first get diagnosed COPD. So they may have all these symptoms of being breathless, coughing, wheezing. a few chest infections, they don't see anyone until they get to crisis point, got A&E, and A&E said, well, I think the patient got COPD. So certainly for the virtual ward that we've been implementing in the last 18 months or so, there certainly has been a few patients that came through that pathway rather than the traditional one, see the practice nurse for chronic disease management for other reasons because they smoke, they get referred to the chest clinic or through the GP. Some of them actually come through walk-in center, come to A&E. And the prevalence is going up for COPD, maybe because we are a little bit better in terms of making diagnosis than before. And also maybe we think a bit harder, so when do we suspect somebody may got COPD in clinical terms? Smoking history, significant smoking history. So what I mean by significant smoking history would be somebody who have a 10-pack year smoking history. So 1-pack year smoking history is when patients smoke 20 cigarettes per day, every day for 1 year. That's 1-pack years. So 10-pack years would be a patient who smoke 20 cigarettes per day, every day for 10 years. Or somebody who smoke 10 cigarettes per day, every day for 20 years. There will be 10-pack years. That's significant. And also a patient with symptoms of being breathless, coughing, wheezing, recurrent chest infection. I think that's when we've got to think, do we think he or she has got COPD? Obviously, look out the patient with COPD, very costly. I'm sure there's also a cost with a virtual ward as well. But why is it important to have a virtual ward? Well, I think it plays an important part because one of the major costs of looking out the patient with COPD is actually recurrent admission to hospital. So part of the remit of virtual ward is get them out of hospital a bit quicker. So actually we can reduce the number of beds they use. So hopefully the beds can be used for a patient with other medical or surgical conditions. Secondly is to support the virtual ward, hopefully might help to reduce readmission hospital because the incidence of readmission hospital within 30 days of discharge is pretty high. It's between 20 to 30%. If this can be reduced, that can actually make a significant impact to the cost of the NHS. Many people die of COPD as well. On average, every year, we lose about 30,000 patients with COPD. So what are the causes of COPD? I kept going on about cigarette smoking, but actually about 80% of COPD caused by cigarette smoking. The other 20% could be related to the patient occupation, especially those patients who work in very dusty environments, such as patients in the building industry, people who work on the road because of the exposure to petrol fumes, diesel fumes. These can also lead to occupational COPD. But I also mentioned before, some patients also get genetic reasons as to why they get COPD. At the moment in time, the only genetic condition that we know of is alpha-1 antitrypsin deficiency. But I think in reality, there may be more than just one genetic condition, because if we look at our patient in closer details, these COPD can come in a cohort of a family. I'm sure you've also met patients who have smoked very heavily for many years. They don't get COPD. None of the family members get COPD, although they all smoke very heavily. Whereas we also seen families where, yes, they have smoked, they may have got 10-pack years, which is not high, but it's significant, and all of them got COPD. So there must be some genetic predisposition in some patients to go on to develop COPD. There's probably some genetic reason why some patients are actually protected from developing COPD itself. So how do we make a diagnosis of COPD? 4 things really. Number one, we've got to make sure the patient hasn't got asthma. I mentioned before, asthma tend to get more diurnal variation symptoms, more nocturnal chest symptom, waking them up. Asthma, it can reverse with treatment, so patients get good and bad days, whereas COPD is a one-way traffic, it will get worse and worse. The other criteria we make diagnosis would be symptoms. So once again, breathlessness, cough, sputum reduction, wheeziness, chest tightness, and also an increased propensity to chest infections. The third criteria would be spirometry. So classically, we want to see evidence of airway obstruction. That's when the FEV1 to FVC ratio being less than 0.7 or less than 70%. And the fourth criteria are risk factors. So smoking, occupational history, that's what we ask for when we come and take the history from the patients. any family history like alpha-1 antitrypsin deficiency. So the patient got tick all 4 boxes. So risk factors, symptoms, spirometry, family history, smoking history. They take all those. Most likely got COPD. Let's jump some of those slides, otherwise we won't finish. Spirometry's got a number of utility. Just briefly, number one, they help us make diagnosis. I mentioned before, in patient COPD, if you look at the bottom left-hand corner, the FEV1 to FVC ratio should be less than 0.7 or less than 70%. But the FEV1% predicted will give us a guide about the severity of COPD. So COPD can be classified into mild, moderate, severe, and very severe on the left-hand side, as you can see. So if they've got an FEV1% predicted of more than 80%, that's mild. If the FEV1% predicted is being between 50 to 79%, that's moderate COPD. For patients with severe COPD, that's when the FEV1% predicted being between 30 to 49%, and anything less than 30% is very severe. Earlier, I also mentioned that I'm going to show you a graph that tells you about the progression of COPD itself. So this is the graph I want to show you. It's called the Fletcher-Petal curve. It was published in the British Medical Journal in 1977. So nearly 50 years or thereabout, 46 years old. So we know that if you look at the top line, the black line, this shows that the lung function deterioration as patients get older. These are patients who never smoked. Okay, if the blue line are those patients who smoke cigarettes, so you can see that for those people who smoke cigarettes, the lung function deteriorates quite quickly. But the dotted line show that at any point for anyone who smokes cigarettes and they decide to stop, the lung function deteriorations tend to slow down. So once again, go back to what I said before. So for patients with COPD, they continue to smoke, they tend to progress a lot quicker. Whereas for patients with COPD who stop smoking, there's still a degree of progression, but the progression actually slows down a lot. Sometimes it's important to illustrate the patient the importance of smoking cessation using this graph, because some patient will tell us, look, what's the point to stop? It's too late. I've got established COPD, so what? But actually, regardless how bad the COPD is, by stopping smoking, it actually can slow down the progression of lung disease. By stopping the progression of lung disease, it can actually help to reduce exacerbation rates. From our point of view, part of the virtual ward is good, important, because that might help to reduce exacerbation rate. And that's the reason why smoking cessation is so important in the management of COPD. There are also ways for us to assess the degree of breathlessness and the impact of COPD on an individual patient. So on the left-hand side is what we call the modified MRC dyspnea score. So it's a subjective score for the patient. We give them this table to look and ask them from 0 to 4, what do you think is your degree of breathlessness? So 0 are those patients who only get out of breath with strenuous activities, so really not that breathless. If the patient said, I've got a modified MRC score is 4, that means they're either housebound or they get breathless when they get dressed and undressed. So anything between 0 and 4, so 1, 2, 3, somewhere in the middle. And then on the right-hand side, get the CAT score. I don't think the CAT score is one of the core requirements for COPD annual review. It used to be, I think, before 2019. But it still got its utility. It basically look at the impact of COPD on the patient's day-to-day life. So they basically, the patient will look at this. They've got 8 questions. They're supposed to give themselves a score from 0 to 5. So the maximum score the patient can hit would be 40. And the suggestion is that if anyone who get a total score of more than 10, that means the COPDs have an impact on their quality of life. I won't talk about spirometry anymore, but spirometry is helpful to make diagnosis, and serial spirometry also allow us to gauge the progression of lung disease in an individual patient. What about the management of COPD? Well, I think this is probably the most relevant part. So before we offer any pharmacological management, it is important that we address the non-pharmacological aspect of COPD itself. So number one, smoking cessation. I've banged on it for quite a long time. It is vitally important. Secondly, pulmonary rehab. So when do we offer patients for pulmonary rehab with COPD? So NICE suggests that anyone with the MRC dyspnea score of 3 or higher. So if we go back to here, so I said MRC score of 3, but that's actually MRC score of 3 is equivalent to a modified MRC score of 2. Okay, so if the patient actually say, I walk slower than most people at the same age, and because I get breathless, or the patients have to stop because of I get out of breath after walking at own pace on a level, that's when they've got MRC score of 3. So basically 3 or higher, they can potentially be for pulmonary rehab. NICE also suggested that anyone who feel that the COPD is debilitating enough, they can also be considered for pulmonary rehab. All patients should be given a self-management plan. So self-management plan will comprise of, inhaler technique, also explain to a patient when they may have developed symptoms of an exacerbation or flare-up so that they know when to use the rescue pack or when they actually seek medical help. And it is also important for us to address the patient comorbidities, not just COPD alone. So once we've done that, we can consider the patient for inhaled therapy. So this is just a slide to show you that there are many options when you come to COPD management or treatments. But of all these, I don't know, inhaled therapy, oxygen, pulmonary rehab, mucolytics, smoker cessation, CT scan, nebulized therapy, which one do you think is the most important part for COPD management? You can answer it quietly, but I would say smoker cessation is the key um, for a number of reasons. One, because 80% of COPD death is attributed by cigarette smoking. Between 25 to 30% of the adult COPD patients have got a significant smoking history. So let me rephrase again, I beg your pardon. So about 25 to 30% of long-term smokers will develop COPD. Interesting, because I suspect most people probably think that the number should be higher than that. Because if I turn around to say that actually between 70 to 80% of patients who smoke heavily actually do not develop COPD. So not everyone does. There must be some genetic predisposition for some people to go on to develop COPD. But I don't usually tell patients by saying, oh, well, it's okay to smoke because, 70% of patients who smoke cigarette don't get COPD anyway, so don't worry about it. I never say that. But I just want to highlight to you that not everyone gets COPD or who smokes cigarette gets COPD. Therefore, don't just assume that because they smoke heavily, they got cough, they got COPD itself. I think the thorough history taking, spirometry, plain X-ray are all very important in terms of making the correct diagnosis. Smoker cessation can also decrease the risk of hospitalization for COPD. It can also lead to a 50% reduction in decline in lung function over a course of time. So that's the reason why smoker cessation is so important. And smoker cessation has also been proven to be very cost effective. This is an NHS cost pyramid for management of COPD. So anything at the bottom of the pyramid is highly cost effective. Anything at the top is the least cost effective. You can imagine after vaccination, which is about £5 to £6 per year. Smoker cessation is actually the most cost effective management of COPD because it prevents disease progression, prevent exacerbation. It can help to improve quality of life of the patient. So that's the reason why smoker cessation is so important. So what are the goals for COPD treatment then? So according to Goal 2020, there are a number of things. So one is I think it's important for us to reduce patient symptoms, especially recurrent exacerbation rate, reduction in exercise tolerance, improve the quality of life. These are important. And secondly, we should reduce the risk of progression of lung disease, exacerbations, hospitalization, and also mortality. This is the inhaled therapy algorithm produced by NICE for patients with COPD. So I just broadly divided it into two parts, the right half and the left half. So in the left half are these patients with COPD alone with no asthma. So NICE suggests that we should give them a dual bronchodilator, LABA-LAMA. However, if they go on to get recurrent chest infection, they should be considered for triple therapy, which is LABA, LAMA, and ICS. Currently in the market, there's only 3 drugs which are triple therapy. They are Trimbo, Trelegy, and also Trexio. So that's what we tend to see. On the right-hand side are those patients with COPD with asthmatic features. So NICE suggests that as a first line, they should be given a LABA and inhaled corticosteroid. One example would be Foster. However, if the patient has day-to-day symptoms that affect the quality of life and also had maybe one severe or two moderate exacerbation, they should be given triple inhaled therapy. So one severe exacerbation is defined as hospitalization. Moderate exacerbation is when the patient do not need to be hospitalized, but yet again, they do need antibiotic steroids. That's probably managed at home. I'll go jump some of these slides, otherwise we'll never finish it. But increasingly, we've been using more inhaled corticosteroid. One is inhaled corticosteroid should be used if we think the patient's got asthma and COPD overlap. But from this study on the left-hand side, you can see that for those patients who have high blood eosinophil count, yet again, they're not giving inhaled steroids. The risk of exacerbation is much higher than patients who have got normal eosinophil level. However, you look at the right-hand side, and so once inhaled corticosteroid been given, you can argue that regardless of the blood eosinophil count, as long as they're given inhaled corticosteroid, the rate of exacerbation is the same as people who's got normal eosinophil level in the blood. Currently, these are the inhalers available in the market. Many, that's why it's very confusing. But what about device? Device is very important because if the patient can't use the inhalers properly, they're not going to get the best out of the inhalers. Therefore, they're not going to get all the benefits for the medication. And secondly, when we give inhalers itself, especially what we call dry powder inhaler, now for the reduction of carbon footprint and sustainability, I think we should do everything we can to reduce the carbon footprint. So dry powder inhalers actually can carry far less carbon footprint than what we call the metered dose inhalers. Therefore, if all we can do is actually offer patient dry powder inhalers, so hopefully that will lead to less damage to the environment itself. Let me just jump some of these. So apart from inhalers, what else can we use for breathlessness? Nebulized medications. So for those of you not familiar, nebulizer, basically you put some liquid into the mask, and by plugging in the nebulizer machine against a wall socket, the nebulizer will actually change the liquid into a fume. So the patient keeps breathing in over about 5 to 8 minutes. So hopefully this medication can help to open up the airways, reducing the patient's symptoms of breathlessness and wheeziness. There are also other oral pharmacological management that we use for COPD. One would be the use of mucolytics. So in the market currently available would be the carbamazepine and acetylcysteine effervescence. So some patients may complain of difficulty with sputum clearance because it's quite thick and sticky, and thereby giving them mucolytic can help to with sputum clearance. And the other medication we use would be oral theophylline, like unifilin. Nobody exactly know the mode of action of this medication, but there's some reports to suggest that theophylline can help with bronchodilation. It can also lead to symptom improvement and improve lung function. Therefore, for those patients who are very breathless, they need any oral supplementation for the COPD management. We do usually suggest introducing oral theophylline as an option. I mentioned briefly about azithromycin, which are long-term antibiotics. So azithromycin has been used in COPD for over 10 years. This was published in the New England Journal of Medicine in 2011. So it showed that if we select the right patient, give them azithromycin, that can help to significantly reduce exacerbation rates. And that's been increasing evidence show that actually does help to reduce some of the episodes of hospitalization. But to initiate azithromycin is not easy because azithromycin comes with a number of potential side effects, such as tinnitus, ototoxicity, cardiotoxicity like arrhythmia, palpitation, hepatotoxicity, liver dysfunction, and also nausea and vomiting. So therefore, before we give azithromycin, the British Thoracic Society guidance suggests that all patients should have a baseline ECG to rule out arrhythmia beforehand. They should also have a baseline low function test. Just make sure the low function test is not deranged before we start treatment. And once the patient has been established in treatment, ideally they should have a repeat low function test in about 4 to 6 weeks, and also repeat ECG to make sure the introduction of azithromycin has not led to QTC prolongation on the ECG. Treatment of advanced COPD, we talk about pulmonary rehab, long-term oxygen therapy, non-invasive ventilation, and also palliation symptoms. And what is pulmonary rehab? I told you about the selection criteria. So usually a patient with MRC score of 3 or higher, or they feel that they're dislabeled by the COPD. Pulmonary rehab has got 3 main components. One is the aerobic exercise session. The second one, anaerobic exercise session. And thirdly, is to work with our physio to do some strength training exercises as well as education. So the aerobic exercises would be maybe walking on a treadmill, maybe using the stationary bike, or do some rowing. And aerobic exercise would be the use of exercise bands, some light weights that may help the patient build up some muscle bulk, therefore making their mechanics better, improving their work of breathing. And lastly would be the exercise program, which usually include smoking cessation, inhaler technique, the introduction of different inhalers, what they are for, and also enable the patient to recognize when they get a flare-up, because if the patient are not aware they've got a flare-up, how do we expect them to be able to take their rescue pack effectively, and how do we expect the patient to seek medical help when they really need to? I'm going to jump some of these slides about oxygen therapy, but for the purpose of virtual ward, usually we don't tend to do a formal oxygen assessment unless the patient has been 4 to 6 weeks free from exacerbation. On oxygen come in three different types. One is long-term oxygen therapy, the one that's 16 hours a day. Second one is what we call ambulatory oxygen therapy, which is like a 10-pound cylinder that the patient can carry around, especially when they go out. Therefore, they're able to do a bit more with the oxygen on board. And the last one is what we call short burst oxygen therapy. That's when the patient actually is not hypoxic. They just need a bit of oxygen just to stabilize the chest. They can use the oxygen for several minutes per day as long as they help. Non-invasive ventilation, I will just jump through some of these. These are the patient with advanced lung disease. That's when they get chronic hypoxia and also get hypercapnia and also become acidotic. That's when we should refer the patient to to our local ventilation unit so that they can be considered for what we call domiciliary non-invasive ventilation. Lung surgery, I'll just bring up one type, lung transplantation. So when do we suspect a patient may need lung transplant? Usually we want them to be less than 60 years of age. They don't smoke anymore, they've done pulmonary rehab, they've been very diligent with the medication. If they still find that the symptom very debilitated, they got very poor lung function, then lung transplantation may be something that should be offered to the patients. And what about treatment for exacerbation itself? So first and foremost, how do we define exacerbation? So if we look at the right-hand side, NICE suggests that exacerbation is a sustained acute onset worsening of patient symptoms from their usual stable state, which goes beyond their normal day-to-day variations. So in simple terms, is patient cough up more phlegm become yellow, green, more breathless, more wheezy. That's when they got exacerbation. So treatment should be given them a bronchodilator to address the breathlessness. So you can use a long-acting beta agonist and also a muscarinic antagonist. They should also be given antibiotic steroids. So usually the length of antibiotic will be 5 days. This is a NICE guidance when it was updated in 2019. They feel that the shorter the course, the better, because by using prolonged course, it increases the risk of MRSA, C. diff, and so forth. The patient should also be given oral corticosteroid because it can help the patient recover quicker. It can also lead to an improvement in the patient's symptoms, especially with breathlessness. So, of course, in patient hypoxic, they should be given oxygen. But generally speaking, in patient who continue to smoke cigarettes, smoking cessation is vitally important. In fact, we do expect patient to have full smoking cessation before we offer them oxygen, because imagine that the mixing of cigarette smoke and oxygen can be highly dangerous. I'm going to just go through these slides very quickly. What I'm trying to say is exacerbation doesn't just lead to hospitalization. It can also lead to a deterioration in lung function. Once a patient have one exacerbation, if you look at the left-hand graph, very soon they get a second one, then soon they get a third one, fourth one, fifth one. Therefore, from our point of view, it is important to break the cycle. I'm going to jump some of these slides because I'm just going to summarize the management of COPD itself. So we talk about how do we make a diagnosis of COPD. Once again, it should be a combination of patient symptoms, spirometry illustrating airway obstruction. That's when the FEV1 to FEV ratio being less than 0.7 or less than 70%. The patient should also have risk factors, usually cigarette smoking, and spirometry got to be able to demonstrate evidence of airway obstruction. Okay, so I'm going to stop here. I'm going to stop sharing. I'm happy to take questions. All very quiet.
Sorry,
No
Dennis,
question posted.
would people prefer if I stop the recording whilst they ask questions? Would you prefer that? No reply. Shall I stop recording then, or?
Okay, sure, yeah, go for it, Claire.
Yeah, yeah, okay.
Or am I just so clear that there are no questions?
Okay. I'll switch the recording off and then we might be a little bit more confident to ask questions.